Hello, everyone. I'm Dr. Russell Barkley, and I'm a clinical professor of psychiatry at the Virginia Commonwealth University School of Medicine here in Richmond, Virginia, in the United States, of course. In this lecture, I'd like to speak with you about the assessment of ADHD in children and adolescents. We're going to be going through a variety of methods and issues, but these are important to consider because of several widespread misunderstandings about the methods and the issues involved in the assessment of children and teens with this condition. To begin with, we're all familiar with the DSM criteria used for the diagnosis of ADHD. These criteria stipulate that a child has to have at least 6 symptoms on either of the 2 symptom lists, which comprise symptoms of inattention, of which there are 9, or symptoms of hyperactive impulsive behavior, of which there are also 9. Children have to have at least 6 of those symptoms. For adults or teens older than 18, just 5 symptoms are necessary, although I recommend that the threshold of 4 be used in those cases because it has more scientific evidence supporting it than what is recommended in the DSM. These symptoms must be developmentally inappropriate, and that's established through several means. First, by requiring a large number of symptoms on either list. Second, by requiring that each symptom occur often or more frequently in the child's life. That's very important because most people don't use that word often in describing some symptoms that they might have of this disorder. Only about 3 to 10%, roughly, of parents describe their child as showing one of these symptoms, often or more. So that restricts these symptoms to people who are developmentally inappropriate in the frequency and severity of this particular disorder and its symptoms. Finally, and later, we'll discuss using rating scales of ADHD to also establish the developmental inappropriateness of the child's behavior relative to their age and sex. Now, we also require that the symptoms have endured. That is, they have to have lasted at least 6 months or longer. And in the case of children below the age of 5, that is, those in the preschool years, I recommend that you require at least 12 months duration of symptoms. We want to be sure that these symptoms are an enduring feature of the individual and not just a temporary developmental or situational reaction to circumstances. And research has shown that children whose behavioral problems last at least a year or longer during those preschool years are highly likely to have a stable set of traits or attributes that will continue into their school age years. We also established that the symptoms have to have been pervasive. That is, they must occur in more than one setting or situation, such as at home, in the community, in school, and so on. And this is to establish pervasiveness of symptoms. One of the most important criteria, however, besides the presence of these specific symptoms, is that the symptoms must be leading to impairment in major life activities. If there's no impairment, then it's hard to argue that a disorder is present. So we want to make sure that we've established that the child is impaired in their home functioning, adaptive behavior and self-help skills, social functioning, educational functioning, and so on. So establishing impairment becomes a priority in the evaluation of children and teens for any mental disorder, and especially for ADHD. Now, the DSM requires that symptoms have developed by age 12 years. I suggest that you ignore that number. There really is little evidence to establish it. Nature is certainly not that precise in the onset of a disorder, and no other Axis 1 disorders require such a precise age of onset, so why should this one? Also important is understanding that the reliability and therefore the validity of a parent's recall of the child's onset of symptoms is very poor. Parents are often off by as much as 2 to 5 years in reporting when a child's symptoms developed relative to when they actually developed and were assessed in research studies, such as longitudinal studies like my own, that have followed children over time into adulthood. So don't put much stock in establishing a precise age of onset. Instead, onset sometime during the developmental period, say up to age 18 to 24, is reasonable enough. Even then, people can develop ADHD secondary to neurological trauma, diseases, tumors, strokes, and other neurologically compromising events. These individuals would be said to have an acquired form of ADHD, but it resembles in many ways the features of idiopathic or developmental ADHD, which is often of a more genetic form. Now, the DSM does require that you have to rule out other disorders as likely explanations for these symptoms, such as anxiety, depression, severe intellectual disability, ASD, which stands for autism spectrum disorders, and childhood psychosis. But usually, those disorders are comorbid disorders rather than rule out disorders. There are very few disorders that disrupt attention, inhibition, and control or regulation of activity level dating back to childhood and that are chronic and enduring. So anxiety and depression can produce episodic forms of inattention, but even then they don't give rise to the poorly regulated and impulsive behavior we see in ADHD. If anything, their attention disorder resembles that of sluggish cognitive tempo, or what I call concentration deficit disorder, which is a very different disorder on which I have another lecture and also a video on YouTube describing this particular condition. I won't have anything more to say about that other attention disorder, other than that it's much more commonly seen in conjunction with internalizing disorders, intellectual disability, and especially autism spectrum disorder. Now, the DSM-5 has also stated that there are no subtypes any longer for ADHD, and that's a good thing, because subtyping implies that there are qualitative differences or different kinds of ADHD, and there really are not. There's only one ADHD in the human population, and it varies in severity, and it also varies from time to time in the relative severity of the inattention versus the hyperactive or the impulsive symptoms. But that variation doesn't imply some qualitative difference or a different kind of ADHD. It's simply ADHD fluctuating over time and circumstances. And so the DSM-5 now uses the term presentations in order to represent the level of symptoms someone is showing at this particular time. And that's all it's meant to convey. It does not convey that the individual has a different kind of disorder. Indeed, people can go through all three presentations of ADHD simply growing up with ADHD, starting out with the hyperactive presentation, which is much more common in the preschool years, and that's because the inattentive symptoms, which are likely to represent executive functioning, take another few years to develop before they become severe enough to diagnose. But by school age, those symptoms are also present, and the individual is re-diagnosed with a combined presentation. By late adolescence, and especially into adulthood, the hyperactive symptoms have usually declined markedly to where the person no longer has 5 or 6 symptoms on that symptom list. And in that case, we re-diagnose them with the inattentive presentation. But the individual isn't going through 3 different kinds of ADHD. They're just showing the developmental course that is rather typical of ADHD itself. So let's stop referring to types of ADHD. Now, to help you with assessing ADHD, I'm going to explain how a clinical researcher like myself views those 2 symptom lists and what they represent, because this is what you're going to listen for in the reports of parents and teachers in order to determine if ADHD is the most likely disorder the individual has. Now, when we look at ADHD, we know that there are 2 neuropsychological traits that are not developing appropriately in these individuals. As we've said, one of them is a set of symptoms that represent disinhibition, poor impulse control, or what some people call executive inhibition. These are the hyperactive impulsive symptoms in the DSM-5. But the hyperactivity represents a problem with motor inhibition in the brain. So it's just as much an indicator of poor inhibition or impulse control as are the 3 specific verbal impulsivity items. Now, that speaks to a problem with this symptom list in the DSM, and that is that not only does the child or adult with ADHD have problems with motor inhibition, which they do, and with verbal inhibition, such as excessive talking or interrupting, as reflected in the DSM-5. But they also have a more cross-modal problem with inhibition, and that is reflected in impulsive cognition. That is, their thoughts often come to them rapidly, poorly suppressed, and are often irrelevant to the goal at hand. These can often lead to very rapid decision making, as if the individual is sort of making automatic decisions without careful contemplation or deliberation about the consequences likely to occur from acting that way. So their cognition is not only impulsive and often filled with disorganized and irrelevant thoughts, but it often leads to very quick decision making. The impulsivity is also reflected in a problem with motivation. The person with ADHD prefers smaller, more immediate consequences that they can obtain very quickly, rather than turning away from pursuing those small near-term events to pursue longer-term, more socially meaningful and more valuable consequences in the future. You of course know this as deferred gratification. Behaviorists often refer to it as temporal or reward discounting, and behavioral economists sometimes call it a high time preference. It all refers to the same thing, a propensity to pursue immediate and short consequences over longer term, more important and larger consequences. And that reflects an emotional or motivational impulsivity. Now, speaking of emotion impulsivity, ADHD is not recognized in the DSM as having an inherent problem with poor emotional self-regulation, but it does. And that problem with emotion regulation has been recognized throughout the 250 years that ADHD has been discussed in the medical literature, going all the way back to 1770 to 75 in the first medical textbook published in Germany by Melchior Adam Weichert. And from there forward, all theorists who have talked about ADHD have included problems with impulsive emotion and poor self-regulation of provoked emotions in the disorder. But the DSM does not. So you need to understand that's a major flaw with the DSM. Poor emotion regulation is an inherent and important component of ADHD, as I discuss in other lectures of mine I have on this disorder. What we're seeing here then is very quick expression of emotion, but the emotions are provoked, usually situation specific. They're of a short duration, and they're rational. They make sense to us. We can understand why the person with ADHD feels the way they do. But where they differ is that they show immature control over these emotions. That is, the ability to engage in the top-down executive management of the emotion for their social well-being is impaired. That's an executive function problem, not a mood disorder. So, again, the emotional impulsivity we see here is one in which the symptoms of emotion are expressed quickly, often provoked, of short duration, usually situation specific, not irrational, but rational. The opposite of everything I've just said would describe a mood disorder, which are long duration, irrational, extreme, capricious, and often not provoked, or at least where there is some easily identifiable provocation. So keep in mind, when we interview parents and teachers about a child or teen with ADHD, we're going to be listening for all of these kinds of inhibition problems: motor, verbal, cognitive, motivational, and emotional. Keep in mind that the hyperactive symptoms, which are evidence of a motor disinhibition, decline markedly with age, such that by late adolescence, and especially by adulthood, they're of no diagnostic value whatsoever. Indeed, after age 30, my own research shows they may become more indicative of anxiety disorders than of adult ADHD. So, keep in mind that the hyperactive symptoms are not going to be expressing themselves much as the person moves into adulthood. Now, the second set of symptoms can be looked at by a clinical researcher like myself as those reflecting poor executive functioning, and particularly working memory. Let's have a quick look at them, because there are various kinds of attention regulated by the human brain, up to 5 or 6 of them, in fact, from arousal to alertness to sustained attention to apprehension, how much you can process at one time, to divided attention, and so on. ADHD is not interfering with all kinds of attention. It's interfering with one specific form of inattention, and that is persistence toward the future. You see, this is a very special kind of attention that only humans possess to the degree that we do. Humans can contemplate a future event, a hypothetical future, and then construct behavior over time to attain that goal or to complete that task. So we can think of this as future-directed attention, persistence toward goals, tasks, assignments, and so on. That's what ADHD is really disrupting: the guidance of behavior over time toward the future. To be able to persist toward goals and tasks, one also has to be capable of resisting distractions, because life will be filled with events that are irrelevant to the goal at hand, and one must be able to suppress responding to those goal irrelevant and disruptive events. And that's the problem ADHD causes. It's one of inhibition. People with ADHD don't perceive distracting events better than others. They react to them more than others do. They're drawn off task from the goal by the irrelevant event. So that's an inhibitory problem as much as it is an attention problem. And once distracted, people with ADHD do not re-engage the goal the way other people would do once they've dealt with the distracting event. The ability to re-engage an incompleted goal is not an attention problem. It reflects a problem with working memory. Working memory is holding in mind information about what you intend to do, how much of it you've done, what's left to be done, that is, your progress along the way to the goal. All of this is conscious, mentally held information being held in working memory and guiding behavior over time. So that if you're disrupted, this mental information is retained and encourages the person to remember what they were doing and come back to finish the goal. People with ADHD have very poor working memory, and as a result, when distractions occur, it often disrupts the storage of that critical, goal-related information. And so now they're skipping from one uncompleted activity to another because they don't remember the goal. And that information, even if it is present in mind, is not powerful enough to regain control of behavior and redirect behavior back to the goal. Think of it this way. ADHD results in a decoupling of attention from mental representations about goals and the future, and results therefore in an overcoupling of attention to the immediate circumstances around the individual. People with ADHD are not inattentive to the now. They're overly attentive to the now. What they're inattentive to is that mental information in working memory about the future. So think of it that way, an overcoupling of attention to momentary and often goal irrelevant events, and a decoupling of attention and persistence from information in working memory guiding behavior toward the goal. So the attention dimension in the DSM-5 really reflects impairment in working memory and executive attention, which is future-directed persistence. So the underlying nature of ADHD is really not one of an attention disorder. It's a deeper, more complex swath of cognitive deficits within the brain's executive functions. The executive functions are those mental mechanisms that permit self-regulation and the cross-temporal organization of behavior to goals specifically and the future more generally. And that's what ADHD is disrupting, which is why I refer to ADHD as EFDD, Executive Function Deficit Disorder. There are at least 7 major executive functions. They develop in a relative sequence and take about 25 to 30 years to fully mature. But by age 30, all of them should be online, mature, interactive, and capable of guiding behavior toward the future. Specifically, these executive functions are self-awareness, or better thought of as self-directed attention in my model of executive functioning. The second is inhibition, that problem with executive inhibition, which I think of as self-restraint or self-directed self-regulation. The third and fourth executive functions are within the working memory system. One is nonverbal and refers to behavior being guided by visual, spatial information. Think of it as visual imagery, but the other senses are involved as well. People can hold in mind sensory representations about past events if they're relevant to completing the current goal. The other form of working memory is verbal. We talk to ourselves, eventually in our mind, and we use self-talk as a form of self-guidance over time toward goals. People may even externalize their self-talk by not just talking out loud, but writing down their goals and the steps to the goals, and writing it in a calendar as to when the goals need to be started. So these do lists and sticky notes and calendars and other ways of listing information in a physical form around us are part of our working memory ability. We are self-directing language at ourselves to control ourselves and make it more likely that we will attain our goals. The fifth executive function I've already mentioned is that of emotional self-regulation, the top-down management of emotion in the pursuit of our goals and our social welfare. And that leads to a sixth executive function, which is self-motivation, because emotions are forms of motivation. And if we can regulate our emotions, we then are given the gift of regulating our motivations. All future-directed behavior requires self-motivation. Think of it this way. You can't pursue a goal in which the consequences lie in the future and have those consequences motivate you. How can they? They haven't happened yet. What motivates us is our thoughts about the future, the mental representations we activate through images and words about those consequences and how much we will enjoy them when we attain them. And it is those mental representations that lead to self-motivation in the absence of external consequences available for goal-directed pursuit. Finally, the last executive function is that of planning and problem solving, the ability to manipulate mentally held information, to play with it in order to recombine it in various clever ways, to try to come up with plans or to solve problems where we've encountered obstacles on the way to our goals. It's really just a form of mental self-play, but we'll call it planning and problem solving. Now, the reason I'm taking so much time here in a lecture on assessment to discuss ADHD as an executive function disorder is because this is what clinicians need to be listening for when they interview parents, teachers, or adults with ADHD about their deficits. We're listening for problems with self-awareness, inhibition, working memory, emotion regulation, problems with motivation, and problems with planning and problem solving. So ADHD is really SRDD, self-regulation deficit disorder, or EFDD if you prefer. Now that brings us to the goals of our evaluation. In the case of ADHD, it's to determine whether the disorder is present or not, and if present, hopefully to differentiate it from other disorders that can interfere with attention. After all, virtually all mental disorders at one time or another interfere with one of the 5 or 6 kinds of attention in the brain. But they don't all produce this kind of inattention. Future-directed, goal-oriented attention. That's what ADHD is producing. So we're trying to determine the presence of ADHD as EFDD or SRDD as part of the evaluation. We are also going to determine whether or not there are other comorbid disorders present, because they're highly likely to be there. Research shows that When patients are referred to clinics, over 80% of those diagnosed with ADHD have at least one other disorder, and over 55% of them have at least two other disorders. So having ADHD by itself is very uncommon. It can happen, but the more common clinical presentation you're going to see is one of comorbidity, ADHD being present with other disorders. And that's okay. That's very typical. And we don't have to get caught up in a chicken and egg issue of which disorder is it. It's usually several. We also need to evaluate the presence of disorders in the parents, because after all, it will be the parents that are going to be required to carry out the intervention. Also, we're relying on the parents as a major source of information about the child or teen, and we want to understand the integrity of that information, and if it's compromised by some mental disturbance that the parent may have, and therefore make their reports a little less reliable. So part of the evaluation of a child or teen for ADHD is briefly screening their parents for possible disorders. Another reason we do that is because ADHD is largely a genetic disorder. So we can expect that a sizable minority of the parents, perhaps 25 to 35% or more of them, will be adults with ADHD. And we need to know that because adult ADHD interferes with carrying out treatments for the child with ADHD. It also interferes with the parent's ability to participate effectively in psychosocial treatment programs they need to learn to deal with this child, such as behavioral parent training. So there are several reasons why you need to screen parents for possible mental disorders. And among them will, of course, be ADHD, but one may also find depression, anxiety, substance use disorders, personality disorders, and possibly even bipolar disorder. Now, as I've said already, when we discuss the DSM criteria, a major criterion we need to establish as present is impairment. So clearly that's going to be a goal of the evaluation as well. We need to determine the child's strengths and weaknesses. Why? Because we're going to rely on those in treatment planning, in getting the child involved in activities in which they have a high likelihood of succeeding in hopes of providing a counterweight to the other domains of impairment that the child is going to have, especially at school. So we need to find avenues of success for a child with ADHD. We're also going to be looking for possible rewarding activities that we can incorporate into behavioral and other psychosocial treatment plans to help with managing this child's behavior. So spend some time talking with parents about what they consider to be this child's profile of aptitudes, abilities, and deficits, strengths and weaknesses. Now, an additional goal of assessment is to delineate the types of treatment that may be needed to deal with ADHD and the other comorbid disorders, and especially to address the domains of impairment we have found in this particular case. Once we've identified that, of course, we also need to discover what resources are available within that geographic region that that family can access. After all, there's no reason to recommend behavioral parent training if you don't provide it, and no other professionals in the community are trained to provide it either. Now, it's possible that parents might be able to obtain that over the internet. For instance, in Canada, there are internet-based telepsychiatry behavioral parent training programs, but they're not very common, especially in the US and Europe. So again, we need to find out, are medications available? Is special education available? Are other kinds of services we need available, such as medical interventions in those rare instances that there's a comorbid medical problem that has to be dealt with? Because again, there's no point in putting that recommendation in the evaluation when we write it up if they're simply not there. we're going to have to focus on what is there. Usually that's medication. Now, we need to determine whether a medical evaluation might be necessary for this child. And some people would tell you that's to rule out whether the child's inattention or ADHD symptoms more generally might be the result of a treatable medical condition. But that's very uncommon. There aren't many medical conditions that can produce this profile of symptoms dating back to childhood that is chronic and pervasive and impairing. And if that's the case, they usually would have been identified by now. But, as I've discussed in other lectures of mine, ADHD is a public health disorder, and it's associated with many different health and medical issues, such as a growing risk for obesity, 2.5 times the risk for a seizure disorder, a very high risk for accidental injuries that are more severe than we see in other children, and often much more likely to occur over time. There's also an increased probability of autoimmune disorders such as asthma, otitis media, and so on, even eczema. And then finally, there is an increased risk by adolescence and adulthood of substance use dependence and abuse disorders, which may also require medical evaluations. Now, I've barely covered the various medical problems linked to ADHD, and I recommend you check out some of my other lectures specifically on that topic. But the point here is that we may need to collaborate with physicians in primary care or elsewhere, such as pediatrics, in order to deal with these co-occurring health problems, in addition to ruling out possible medical causes for the inattention. And finally, the medical evaluation is necessary to determine whether there are any factors that would contraindicate the prescription of ADHD medications to this individual. There aren't very many that are contraindicated, but there might be some, such as a history of cardiac problems in the child or cardiac arrest in the family, or a history of adverse responding to ADHD medications in other family members, which could predispose this child genetically to having more adverse reactions. Finally, we want to identify whether there are any legal issues present in this particular case, issues related to custody, for instance, or, in some cases, issues that might be related to victimization or child abuse. Now, there's a whole suite of information that we need to obtain at the time of referral, at the time that the family calls the clinic requesting an appointment. I'm not going to go through all of these, but I did want to list them for you here because they're, of course, the kinds of information that any professional would collect, or any professional's administrator would collect at the time that a call comes into the clinic seeking an evaluation for ADHD. And you see these here: demographic information, the reason for the referral, who's making the referral, any prior evaluations available and can they be obtained, any previous diagnoses that have already been made of the individual and who made them, are medical treatments in play already, and what kinds of school services might this child be receiving at this time, and any other family or child mental health services that are being provided. And then, of course, here in the United States, we have to ask about insurance coverage because we don't have national health care for everyone. Now, the assessment of a child for ADHD or any other mental disorder is driven by the specific issues. That is to say that the issues we have to address are going to determine the methods that we're going to use to address them. Makes perfect sense, right? So we have to, first of all, focus on the current concerns, their history, their course and chronicity, because that's all part of our DSM diagnostic criteria, differential diagnosis from other mental disorders, establishing developmentally inappropriate symptoms, as I've already discussed, what other disorders are coexisting. So it's not just differential diagnosis of one disorder from another, it's also establishing how many disorders are present, and then establishing impairment, parental adjustment in presence of other mental disorders in the parents, surveying the child and family for their strengths and weaknesses, as I've already discussed, mapping out community resources that we can rely on for our interventions. And then is there a need for collateral professional evaluation, such as by a physician? Now let's take a look at these methods because these are the things we're going to use in the evaluation. As I said, we need to establish what are your current concerns when we talk to a parent or a teacher of a child or teen. And of course, how do we establish that? Through, obviously, an open-ended interview. What brings you to the clinic today? What are you concerned about? And then follow that up with questions that deal with history. The age of onset, though we're not going to put much stock in that age, but how long ago was it? The course. Is it chronic or is it episodic? And then, of course, we need to begin to go into a semi-structured interview about these issues. And you can find that in my new book, which is Treating ADHD in Children and Teens, that will be out in the fall or late winter of 2021. And you could obtain that through Guilford Publications. I have in there a number of forms, rating scales, and a structured and unstructured interview that you can use for this evaluation. We also need to differentiate ADHD from other disorders and determine the presence of comorbidity. And we're going to do that by using, first of all, what we call broadband rating scales that assess the various dimensions of psychopathology in children and teens, like the Child Behavior Checklist, for instance, or the Behavioral Assessment System for Children. And you can see where these are obtained. These usually assess at least 8 or more dimensions of child psychopathology, from depression to anxiety to social withdrawal to inattention to hyperactive impulsive behavior and aggression and so on. And so they're very quick ways to gather information about the possibility that these kinds of symptoms are present. We often send them out at the time that the phone call comes into the clinic for the evaluation, and we require that they be returned to the clinic, completed of course, before we even call the family to give them an appointment. That encourages the parents to get these rating scales done and returned as quickly as possible. And then we'll call you back. It's kind of an incentive to get these rating scales done. So we collect those before the evaluation so that the clinician can examine them before the patient even comes for the appointment, and then be guided by the answers on these rating scales as to questions you might need to ask the parents or the teachers of this child. There's a structured interview, as I've already mentioned, that covers the various DSM disorders in children, and you can find it in my new book, shown here, Treating Children and Adolescents with ADHD. Essentially, what we're establishing here is that you have adequate knowledge of children's psychiatric disorders and know how to differentiate among them and are using appropriate tools or methods to gather that information. Rating scales and structured interviews are the way that we do that. Now, I mentioned developmental appropriateness is clearly part of our criteria for establishing the presence of a mental disorder in a child. And we are going to establish that through several means. First is the DSM criteria itself, as I already said. You have to have at least 6 or more symptoms on either list. They have to occur often. That is, they have to be frequent and severe. They also have to be persistent and pervasive. In addition, we're going to use rating scales of ADHD symptoms sent out to parents and teachers. There are a number of such rating scales. For instance, in the clinics I've supervised, we've used the ADHD-5 rating scale by George Dupal and colleagues from Guilford Publications. But there are other rating scales that contain the same 18 DSM-5 items, such as the Connors rating scales and so on. So use whichever is available to you and that you find more clinically useful. But be sure that they have adequate and up-to-date norms for children, broken down by age and by sex, because we're going to compare boys to boys and girls to girls to establish how deviant the child is, not only for their age, but for their sex. Now, some clinicians will want to use neuropsychological testing as another means of establishing that deficits are present, that is, that the child's symptoms are developmentally inappropriate. I don't recommend that you do so because there are no tests that are adequate in their accuracy of diagnosing this disorder in children or adults that I would recommend them for clinical practice. So they have very limited utility, and I certainly don't use them to make a diagnosis or not with a particular child. More times than not, psychological and neuropsychological testing is used to rule in or out other disorders for which such testing has validity, such as establishing that there are learning disabilities present, or that the child has an intellectual disability. But the use of executive function tests to diagnose ADHD is not recommended. The tests are simply too poor in their accuracy to do so. We're concerned here with what is called positive and negative predictive power. Positive predictive power refers to if a child fails the test, what is the likelihood that a disorder is present, and specifically ADHD. Some neuropsychological tests, such as continuous performance tests, have pretty good positive predictive power, in the sense that if a child gets an abnormal score on such a test, there's highly likely to be some disorder present. It may not be ADHD, however, because other disorders interfere with performance on psychological and neuropsychological testing, such as CPTs, continuous performance tests. So the test might show you that some disorder is likely to be there, but the fact that it can't tell you which one still means you have to go back and do an interview of the DSM disorders to see what may be present. There's only about a 60 to maybe 70% chance that it's ADHD that's present if a child gets an abnormal score on one of these tests. The real problem with psychological, especially neuropsychological testing for ADHD is very poor negative predictive power. That refers to if a child gets a normal score, what's the likelihood that no disorder is present? That is, that the child is simply a typical child. And it's very poor, often well below 50% probability. Why is that? Because many people with ADHD pass these tests. Indeed, in my studies, anywhere from 50 to as many as 75% of the patients we were testing could pass these tests, even though by all other standards and sources of information, ADHD was an appropriate diagnosis for them. So one has to be very careful with normal scores on these tests and simply ignore them, exclude them. They're not going to determine whether ADHD is present or not because they can't. Now, besides the neuropsychological testing that I've mentioned, sorry about that, my slides sometimes go back and forward here, we're going to use behavior rating scales of executive functioning. Now, that might sound like a contradiction. I've just told you that neuropsychological testing isn't useful, and that's true, it's not. But neuropsychological rating scales of executive functioning in daily life are highly useful in identifying not only the kinds of routine executive deficits this child has in daily life, but also even in diagnosing ADHD, which, as I've said, really is EFDD. Now, why does it seem like that's a contradiction between tests and rating scales? Because it is. There is no significant correlation between the results of tests of executive functioning and the results of behavior rating scales of EF in daily life. They're just not significant. And there are more than 30 studies, as well as a meta-analysis in our literature that prove that. So whatever these measures are assessing, they're not assessing the same thing. And as I've argued elsewhere, the problem is not with the rating scales. The rating scales are collapsing information across weeks and months that observers in real life have witnessed in this child in daily life activities. And the tests simply can't do that. Most neuropsychological tests last only 15 to 30 minutes each. A whole battery might last several hours, but they're not collecting that wide a swath of information across various places in natural settings so as to be ecologically valid, which is why neuropsychological tests don't predict much of anything in the life performance of individuals with ADHD as far as their impairments are concerned. That brings me to the next topic. We need to find ways to establish impairment. One way we do that, of course, is through interviews with the parents and teachers about how well the child is functioning. And you'll find those interviews again in my latest book on treating ADHD in children and teens that will be out later this year. But it can also be established to some extent on the very front pages of the two rating scales I recommended, the Child Behavior Checklist and the Behavior Assessment System for Children. Both of those scales have a few questions that ask about friendships, self-care, chores, school functioning. And that's what we're looking for, evidence of impairment, although that's only rather crudely collected on those scales. I have two rating scales that assess functional impairment specifically. One is for children, and the other is for adults, and they're called the Barkley Functional Impairment Scales. And each one assesses 15 different domains of daily life activities and whether or not the individual is performing effectively in those domains. Now, the 15 domains for children, of course, are different than those on the adult rating scale. But as far as I know, those are the only normed rating scales on the U.S. population that can establish impairment. The other rating scales, such as the Child Impairment Scale, do not have adequate norms for that. And social skills rating scales really only focus on one domain of impairment. So have a look at my rating scales if you're interested in getting much more specific information about that many domains of functioning. Now, another issue we've mentioned is we have to establish comorbidity, and we're going to do that by using some of the same methods I've already described. One is using a structured interview of those other disorders: oppositional disorder, conduct disorder, anxiety, depression, and you'll find those in my new clinical workbook. In addition, we need to rule in or out whether learning disorders are present or intellectual disability is present. And we have to do that by using brief tests that assess academic achievement and intellectual functioning. These don't have to be full batteries that last several hours. That's not necessary. We can establish whether or not a problem is present by using the screening or short versions of these tests. And should the child manifest a deficit in any area, then the child can be brought back for further, more complete testing using larger batteries of these constructs. But keep it brief at the beginning so that you don't inflate the time needed to do the evaluation and the cost of the evaluation to the family. Now, I've said that establishing the psychological adjustment of the parents is also crucial in the evaluation. How do we do that? Well, in the clinics I've supervised, we've used the Symptom Checklist 90 Revised. It's a very quick rating scale of at least 8 dimensions of psychopathology that adults may be experiencing. Some of you might prefer to use the adult version of Tom Achenbach's child behavior checklist, the adult behavior checklist. And that's okay too. Any of these will suffice. By the way, I don't mail these out before the appointment because often parents won't understand why we're evaluating them. So please wait until the day of the evaluation to ask parents to complete these rating scales because that gives you a chance to tell them why you're going to ask them to do so. And that is because a child's problems is embedded within a family environment. And that family environment includes the parents and the parents' well-being and how well they're functioning. And in order to understand better the child's difficulties, as well as what kinds of treatments we're going to be able to institute, we also need to understand the parents' functioning as well. Once you've explained that, you can give them these rating scales. Again, I use the SCL90R, but also the adult ADHD rating scales. There are several on the market. I have an adult ADHD rating scale that assesses the DSM symptoms, as well as, by the way, the symptoms of that other attention disorder, sluggish cognitive tempo. But there are the Conners rating scales, and there's also the World Health Organization's symptom screener known as the Adult Symptom Rating Scale, which is, of course, available as well on the internet. But by some means, you need to get ratings of the specific DSM symptoms in the parents. And then some people, like me, often like to get a quick screen for marital functioning because we know that marital conflict, that is marital dissatisfaction, can have a pervasive effect on family functioning, often resulting in behavior problems in the child, such as defiance or depression, and often leading to problems with implementing treatments for that child, such as behavioral parent training, for instance. So I like to screen for marital functioning if the parents are married and cohabiting, right? And you can use the Locke-Wallace Marital Adjustment Scale, which has been around for decades and is easily available on the internet. As I've said, we need to establish the child's and the family's strengths and weaknesses, and we do that through, obviously, an interview. Finally, what are the community resources available? And again, we use an interview with that, sometimes also telephone contact with social services or with the school to find out what resources they have for dealing with this child's problems. Now, the parent interview has a variety of features to it. You see them listed here. I'm not going to go over them in terms of what are the purposes of doing an interview with the parent. Hopefully, if you're taking this lecture, you've had appropriate training in doing interviews with families about childhood mental disorders. But these are the kinds of purposes that such an interview would serve. And then again, the content of the interview is pretty straightforward. Any graduate program training someone in a profession related to mental health evaluations will have trained them in interviewing. And of course, what you'll be trained to collect is this kind of information through the interview that you see here. And again, I've already mentioned all of this earlier, such as the parental concerns about the child and their history and so forth. But I just list them here for completeness of this interview process. Now, let me back up for a moment. We do interview the child, but understand that the child's reports are not very reliable when it comes to disruptive behavior or what we call externalizing types of psychopathology, such as defiance, oppositionality, antisocial behavior, aggression, and so on, and including ADHD. So we don't put a lot of stock or a lot of emphasis on what children say about themselves when it comes to those disorders, because they're just not very reliable reporters of that information. And they won't be reliable until they reach adulthood when it comes to self-reports of those disorders. In contrast, children are, in fact, reliable reporters of internalizing disorders, as you see here, such as anxiety and depression. Who better to report on their internal emotional states than the person experiencing those emotional states? So you might want to ask more about those too, and you could put a little bit more faith in the validity of those reports. In general, the purpose of this interview is really more to establish rapport with your patient and to get a first impression of the child, their appearance, some of their developmental abilities, and their personality. And of course, we're going to ask them about why they are there for the evaluation. What's their perception of that so we understand what they've been told by their parents or teachers. But again, we're not using this to make a diagnosis or differentiate ADHD from other disorders. But it's a good interview to use for also establishing the child's interests and their aptitudes and talents. As I've said, establishing strengths and weaknesses is a very important part of the evaluation. Now, I want to return briefly to this issue of psychological testing, just to make that point again. Psychological testing, particularly neuropsychological testing for executive functioning, is not helpful for the diagnosis of ADHD specifically. Here you see one of the most commonly used forms of tests, which is a continuous performance test. This is the Gordon Diagnostic System on the left. Over here is the manual for the Connors Continuous Performance Test, which is done through software on a computer. And there are other versions of these tests as well. I don't mean to pick on these specifically. But my point, is simply to show you that neuropsychological testing is not very good for ADHD diagnosis. You see, ADHD has already been established as a disorder of the brain networks that underlie executive functioning. That's a fact in the bag. ADHD is a neurological disorder of the brain's executive networks. However, when we do psychological testing to assess executive functioning, only 35 to 50% or less of ADHD patients with legitimate disorder fail these tests. So the tests are not very good at detecting this disorder. On the other hand, when we use rating scales of executive functioning, about 89 to 98% of people with ADHD score in the abnormal range on these rating scales. So the rating scales agree with neuroimaging results that ADHD really is a disorder of executive functioning in daily life. It's the psychological tests that are the problem. They have a very low relationship to the executive function ratings, and they also are very poor at predicting impairment in major life activities. So please don't rely on tests in making a diagnosis of ADHD, even though psychological testing might be useful for establishing whether other disorders like learning disorders or intellectual disability are present. Now, if you don't believe me, okay, here is a study that we did with adults with ADHD. Over here are the results of rating scales of executive functioning, and you can see the kinds of executive functions my rating scale is assessing. And you can see here the percentage of patients that scored in the impaired range on the rating scale. That is 1.5 standard deviations above the mean. And we have three groups: an ADHD group, a clinical group of people who thought they had ADHD but didn't meet all the criteria for it, and probably had other disorders too. So you can think of them as kind of a subclinical group of ADHD patients, and a community control group of typical adults. And what do you see here? ADHD adults, or those who complain about ADHD symptoms, even if they don't meet all criteria for the disorder, have very high rates of EF deficits. Now look here at the executive function test battery. In this case, Wisconsin card sort, continuous performance tests, and other measures of working memory, such as digit span, and so on. People with ADHD perform these very well. Only a very small percentage fell in the impaired range on those tests. By the way, it's not just this study. We found it in our longitudinal study of ADHD children followed up to age 27 to 32. Here's the rating scale of executive functioning. Here's the test battery. Note the marked disparity in the results between these two methods of assessment. The rating scales show that people whose ADHD had persisted to age 27 continued to have very high rates of executive functioning deficits. Those whose ADHD had not persisted, many of whom were not normal, but still had some symptoms, they just couldn't be diagnosed with the disorder, had intermediate levels of deficits. And the typical children we followed to adulthood were unlikely to have executive function deficits. But again, look at these tests, and this is a different test battery. But again, these tests have all been said to assess executive functioning, such as the Tower of London and the 5 points fluency test and digit span forward and backward and so on. And you see how poorly they were able to detect the persistence of ADHD into adulthood. So you don't have to take my word for it. There are many studies, such as my own here, that demonstrate this gross disparity between methods of evaluating executive functioning. And the problem, as I've said, lies with the tests. They're simply too limited, too ecologically invalid at detecting executive functioning to be useful. Now, in concluding this lecture on assessment, let me just give you some quick differential diagnostic tips when you evaluate children and teens with ADHD. Understand that ADHD is one of the earliest disorders to develop in children. Indeed, it's one of the 3 earliest disorders to develop, along with intellectual disability and autism spectrum disorder. In contrast, disorders such as anxiety and depression and bipolar disorder often have an average age of onset later than ADHD. So we're looking for onset of ADHD. By the way, the average onset for ADHD, established in a recent meta-analysis of all research on age of onset of all mental disorders, finds the average age of onset is 12. And that's why I tell you to ignore the criteria in the DSM that the disorder must be present by 12, because it won't be in half of the cases you evaluate. It will develop somewhat later. But understand that ADHD develops earlier than many other disorders. ADHD is a chronic disorder, not episodic like bipolar or panic attacks or depressive episodes or things like that. And ADHD is a chronic disorder of self-regulation and inhibition. Those other disorders are not, including autism spectrum disorder. ASD is not a disinhibition syndrome, whereas ADHD is. And even though other disorders can interfere with executive functioning, such as working memory, ADHD interferes with all of the executive functions, not just little narrow ones like self-awareness or planning and problem solving. Autism spectrum disorder does interfere with working memory, but not with inhibition. Also, anxiety and depression from time to time can interfere with working memory and produce inattention, especially of that sluggish cognitive variety I mentioned earlier. But again, it's a different kind of inattention. It's episodic. And disinhibition and poor self-regulation are not present in those disorders. Now, bipolar disorder is interesting because often people with bipolar disorder do have problems with inhibition, particularly during manic episodes. And they do have problems with inattention. So how do we differentiate whether it's bipolar or ADHD? By excluding the ADHD symptoms that are listed on the bipolar symptom list in the DSM-5 and focusing instead on the non-ADHD symptoms, which have to do with mood and with the variability of mood, the cycling, and with things like the lack of need for sleep, hypersexuality, the extreme press of speech during the manic episode. So we're focusing on symptoms of mood, not just on symptoms of inattention. And if the individual has enough bipolar symptoms to pass the threshold for bipolar disorder, even though you haven't used the ADHD symptoms as part of that, then they have bipolar disorder too. Often the two go together. Children with ADHD or excuse me, children with bipolar disorder have a very high rate of ADHD. Between 80 and 95% of them in some studies also have comorbid ADHD. If the bipolar disorder has an adolescent onset, it's going to be about 50% have comorbid ADHD. Whereas if the bipolar disorder has an adult onset, the comorbidity is about 25% for adult ADHD. Still very high, nearly 5 to 8 times higher than one would see in the typical adult population as far as the base rate for ADHD is concerned, but not as high as we see in children. So notice what I've just said. The earlier the onset of bipolar disorder, the greater the likelihood that ADHD will be a comorbid disorder along with it and have to be managed. So it's not either or, it's comorbidity. Now, we're also going to understand that hyperactivity, as I've said, is of little diagnostic value. So please, once we get past late adolescence into adulthood, you really don't have to put so much emphasis on those. It's going to be the problems with executive functioning and emotion regulation that are most likely to be present in the adults. The problems with self-awareness, time management, self-organization, poor impulse control, low motivation, and as I've said, poor emotion regulation will be present too. And I've already covered how to differentiate the emotional deficits in ADHD from a mood disorder, but I reiterate them here. In ADHD, the emotions are short duration, situation specific, often provoked, and are rational. We understand why you're upset. You just shouldn't be showing that degree of being upset. It's an immaturity of emotion regulation. Whereas in a mood disorder, it's long duration, unprovoked typically, lasting hours, days, weeks in the case of manic or depressive episodes and so on. And these are bottom-up, severe emotions. They're irrational, they're capricious, they're extreme. And they overwhelm the individual's efforts at self-regulation, as in major depression or bipolar disorder. So that should help you differentiate what emotional symptoms track with ADHD and what emotional symptoms go with a mood disorder. Now, other things to keep in mind have to do with comorbidity. We really aren't trying to differentiate among disorders so much as establish how many are there. And I've already told you about the high rates of comorbidity in ADHD. And they're going to complicate your differential diagnosis a bit, but I've given you tips about that, about ADHD being the only disorder of self-regulation that's chronic and dates back to childhood or adolescence. The other disorders more likely to coexist with ADHD are shown here. It's not the purpose of this lecture to go into those disorders, just to show you that many of them, particularly oppositional disorder and conduct disorder, are likely to be present. Finally, when we meet with the family after the evaluation in what we call the feedback conference, where we review the results of the evaluation, then I suggest a few pointers here as to how to cover the content. I begin with a summary of why the parents came to us. And if I spoke to teachers, which I almost invariably do, of what I learned from the teachers. So what are people concerned about with this child? What was the reason for the evaluation? Then I take parents through each and every type of information, the interviews, the rating scales, the talks with the teachers, the broadband rating scales, the narrowband rating scales, the psychological testing for academic achievement, any psychological testing for intellectual disability. I go through them one at a time and explain what we found. And then I integrate them for the parents in showing them how I reached the diagnosis of ADHD in that child or teen. I then follow that up with an explanation, very briefly, of the nature of ADHD, its causes, its course, what the risks for future impairments are, which are numerous. All right, excuse me. Let's back up. But you can do that briefly and then refer parents on to the popular trade books, such as my own, that cover all of this in detail. My books, Taking Charge of ADHD and 12 Principles for Raising a Child with ADHD, might be appropriate here, but there are others out there that are quite good as well. In addition, you might recommend some of the videos on YouTube that I've made or others have made that are trustworthy and can review that. My website and other websites have information on ADHD, but you have to be careful and make sure that you pre-screen that website before recommending it. Here in the United States, a good website is that for children and adults with ADHD, which is CHADD, CHADD.org. In Canada, it's CADRA, which is the Canadian Resource Alliance. And in Europe, there will be other resources, such as the World Federation for ADHD, or in the United Kingdom, ADDIS, ADDISS, is a website with information. So refer families to more detailed information, but spend some time going over ADHD. And that's going to lead you, to explain your treatment options for this individual and exploring what's available in the community. And then I review any other pertinent issues that came up in the evaluation. And then if I need to, I connect the family up with other professionals I'm recommending that they see or other resources in the community to help deal with this child. So essentially, what we're trying to do in the feedback conference is share our findings on ADHD, comorbidity, and impairment, improve the parents' knowledge about ADHD, also that of the teachers, by the way, convey the seriousness of the disorder. This is not just an attention disorder. It's a disorder of self-regulation that interferes with virtually every major domain of daily life activity. We want to instill acceptance of the child as a disabled child. This is a chronic developmental disorder for many children. And we want to teach them what I call the 30% rule. And that is, your child has the executive functioning of someone who's about 30% younger. It's just a rough rule of thumb, but it gets the idea across to the parents that their child is experiencing a delay in development, in self-regulation. Hopefully that elicits compassion. After all, this is a neurobiological and genetic disorder that the child didn't choose to manifest. And once parents understand the scientific and neurobiological basis of ADHD, hopefully we see compassion for the child. And then we also have wanted to assess the patient and the family's readiness to change and to accept our treatment recommendations for this child. And we've done that through the entire evaluation process. How have they been conveying information? How have they been receiving the information we're giving? And so on. I also like to encourage patience with the subsequent treatment plan. Parents often get very impatient. They want the disorder corrected tomorrow. But it's been around for years. And parents need to understand that psychological treatments and educational accommodations take time to implement. And the results are not going to be seen for a few weeks, if not a few months. Now, some medications like the stimulants can work very quickly, but even they may require several weeks to identify the ideal dose for that particular child. So counsel patience with your parents. Lastly, end on a note of hope. Despite the chronic nature of ADHD for many, though by no means all children, we need to emphasize that ADHD is among the most treatable psychiatric disorders that we deal with. It has more information available, more effective treatments on the market, particularly medications, that improve the disorder to a greater degree in a larger percentage of patients, and normalizes their behavior in a substantial number of people relative to the treatments available for any other mental disorders. So if you have to have a disorder, this is a pretty good one to have because of so much information and treatment methods being available to help address it. And that's the note we want to leave with parents, inspiring hope. I hope that you have found this lecture useful on the assessment of ADHD in children and teens. And I hope you'll watch for other lectures I have available and participate in those too on other topics related to ADHD. Thank you for listening and for watching, and have a good day.